Mechanical complications after an acute myocardial infarction are life-threatening events that typically occur within the first week following the insult. While their incidence has decreased significantly in the era of primary percutaneous coronary intervention, they still carry very high mortality rates. These complications generally result from the necrosis of myocardial tissue leading to structural failure. Left ventricular free wall rupture is the most dangerous mechanical complication which can occur 3 to 7 days post myocardial infarction. Infarcted tissue becomes soft and shares under intraventricular pressure. Presents with sudden onset of pulseless electrical activity due to acute cardiac tamponade. It's often fatal within minutes. Subacute cases may form a pseudoaneurysm if the rupture is contained by the pericardium. A rupture of the interventricular septum creates an acquired left-to-right shunt. They present with sudden clinical deterioration with a new harsh hollow systolic murmur, usually at the left lower sternal border, and a palpable thrill. Diagnosis is confirmed by echocardiography showing the shunt or a step up in oxygen saturation from the right atrium to right ventricle during right heart catheterization. Requires aggressive afterload reduction followed by urgent surgical repair. Interventional device closure is also an option, but difficulties are often there because the septum is very fragile. Acute papillary muscle rupture leads to acute severe mitral regurgitation. Most commonly involves the posteromedial papillary muscle because it usually has a single blood supply from right coronary artery, whereas the anterolateral muscle has dual blood supply from left anterior descending and left circumflex coronary arteries. They present with acute pulmonary edema and cardiogenic shock. A systolic murmur may be heard, but in severe cases, the murmur may be surprisingly soft due to rapid equalization of pressures between left ventricle and left atrium. They have to be stabilized with vasodilators or intra-aortic balloon counterpulsation, followed by emergency mitral valve replacement or repair.